CataractCoach.com, podcast number 7 with Arsham Sheybani. He's a glaucoma specialist and anterior segment surgeon at Washington University in St. Louis, and he is revolutionizing the surgical treatment of glaucoma. We know he's a brilliant innovator. We've had his video here on the past about the BANG technique, B-A-N-G. Look it up, CataractCoach.com. Innovative way, low-cost way for 1 or 2 US cents to do a glaucoma surgery that's MIGS, minimally invasive glaucoma surgery. But he thinks of glaucoma differently. 20 years ago when I was a resident, I just didn't find glaucoma all that appealing. But now it's a different story, especially when you have Dr. Sheybani explaining how he sees it as a full spectrum of surgical care and how he integrates that into anterior segment surgery, reconstructive surgery, even simple cataract surgery. It's all in the same spectrum for him. I am really fond of his work. I think he's brilliant, and I learned so much from this interview. It's just an hour, so quick and easy. Remember, you can always get our podcast on Apple, Amazon, Spotify, Google, wherever you find your podcasts. But check it out. I think you'll really enjoy it. So welcome to the Cataract Coach podcast. I want to welcome Arsham Sheybani, who's at WashU in St. Louis. Technically, you're a glaucoma specialist, but I actually admire your work because you're doing everything in the anterior segment, which I think is a very different way of thinking about, let's say, glaucoma than we did years ago. Tell me more about that.
Yeah, it's interesting. I really appreciate being on here. You impact a ton of our residents, a ton of our trainees. I mean, it's before we even jump into that, it's funny because I will have residents and fellows tell me about techniques that they saw in your videos. So there you go. But if we kind of think about anterior segment and glaucoma, they really tie in together. When I was a resident, I assumed that a lot of the post-trauma stuff was going to maybe like cornea or retina, and they still do a large fair share. But a lot of these, post-traumas or surgical complication cases, they end up leading to high pressures. And so I think it's just a natural union that you have to be able to do the anterior segment side as well as the glaucoma side so you don't have to stage surgeries for patients.
Yeah, I think that's a really great move. Because, in the old ways, like I would think of, I'm older than you, 20 years ago when I was a resident, the thing was like, just you do whatever you want in the anterior segment. When the pressure's high, then dump it on the glaucoma specialists, and they'll do a tube or a trab.
Yep, that's exactly how it was, right? And it was when we were just treating pressure and not mechanism, that's what you did. You lowered the pressure, you added a drop, you did a laser, you did a tube, you did a trab. We just tried to get to a number. And I think glaucoma's gone very mechanistic now, as it should. And so when you start to treat mechanism, you're going to have to start to treat the anterior segment. There's just no way around it.
Well, and I love how you just combine even, like you were saying, the complicated trauma cases where the patient has big trauma. They have no capsular support left. You have to take the lens out, do a vitrectomy, do a Yamane. And yes, you've got to manage the angle disease, the angle recession, whatever they've got, all in one sitting, which is what I thought was amazing.
You nailed it. I mean, today, part of my other hat is actually work with our retina fellows. And they get phacos, they get IOL cases. We had 6 combined cases that the fellow did today, and it included pupilloplasties, and the angle stuff comes with it. And if you don't understand how to treat the IOP in the least invasive way, then you're potentially tubing everybody, even if you're a good anterior segment surgeon. But if you're just like a MIGS or angle surgeon, I mean, you could run into trouble too, because these cases sometimes end up with a little hypotony when you're making scleral wounds, and you have passes for even Yamane or like a 4-point fixation technique. You have to learn that, hey, listen, like maybe you have to tilt a little bit toward viscodilations with your goniotomies and pressure management, even post-op, like when to add Diamox, when to take their glaucoma drops off, when to continue them. It gets pretty complicated to the point where I think if you're only treating glaucoma or IOP, or if you're only treating the anterior segment, you're going to run into more issues than if you're someone that kind of has that idea of treating them both together.
So you're basically doing the entire spectrum, which I thought was the most amazing part. Any part of the spectrum of glaucoma is your cup of tea.
I love it, man. It is, look, and it's one of these things, Uday, you know how it is, that you do not win them all. And I never want to give anyone that impression. And in fact, I want to give people the impression that I don't care who you are, people are going to lose some of these battles. You just know that you're trying to do the best that you can, but You handle a broad spectrum so that you see a broad variety of problems that come up. And I always tell the residents, it is shocking to me how many things can happen in such a small space.
Right? Exactly.
It's incredible. It's incredible. And you have to be prepared for it. And the only way you can be prepared for it is either you have the forethought to kind of, be a step ahead to predict how things occur. But you know how it is with like PCRs. It can happen on a whim. Or you have to have so much experience. Actually, I think that's why teaching's so critical. Like what you're doing with your videos, like reviewing videos, staffing resident cases, you're going to learn way more. There are things that will happen in their hands that wouldn't happen in yours, not because they're worse than you or you're better than them. It's just we all think about things differently. Slight little changes in position, reactions are different,
right?
And it's a super interesting thing to think about. But I don't think you really understand the gamut of what can happen in complications until you teach.
You're right. Well, I was talking to someone earlier today about anterior vitrectomy, and he says, about how many anterior vitrectomies have you staffed with residents? I said, well, let's call it one a week for the last 22 years, so 1,000.
Yeah.
So they're like, wow, that's quite the experience.
Well, but it's unplanned. And what's crazy about that is, like you go in and you have a case that's already got VIT moving forward. Like there's a plan to manage it.
Sure.
Like you have to think on the fly now.
Surprise.
Totally different ball game. But I think also like a very valuable one. And when you go back to thinking about the glaucoma surgeon, sure, I think you can really do a good glaucoma practice and not do the anterior segment stuff. I'm not saying that at all.
Sure.
But if you want to try to minimize the number of procedures that a patient has and kind of be someone where like the buck stops at you as much as it can, I think you really do have to combine the two. And then that leads you down a different path, right? Like you start going down the refractive path, the IOL exchanges for if someone's unhappy with a multifocal or dysphotopsias or refractive outcomes. And there's still times, like Uday, honestly, I wish that I did LASIK surgery and I did more keratorefractive procedures because I think I could augment my armamentarium. But at some point, like you kind of have to like draw the line as far as what you do.
LASIK surgery is much easier than glaucoma surgery. I'll be the very first to admit that. But you know what I love is there's something about your fellowship. I had a senior resident this last year who just matched with you, Gio Campagna.
I can't wait.
And he's an amazing young man. Amazing. Yeah. And he says, of all the entire fellowships in the entire country, and there are a ton of great fellowships.
Yeah.
He's like, no, I want to be with Arsham Sheybani in Washington. I want that fellowship. I was like, wow, you better bring your A game, Arsham. No joke.
No, it's funny like thinking of it that way because I look and I'm like, man, our section is just fantastic. Like you get such a well-rounded experience, and just watch. Give it a couple of years, but there's a couple of our younger faculty, and it's crazy. Like now, I guess I got to call myself old, but they're really going to be all-stars, anterior segment and glaucoma-wise. But we are so thrilled as far as what we've been able to build. I mean, when we started, we had just one fellowship spot. And slowly kind of built it to the point where the residents were getting good experience.
Wow. And
until they got good experience, we really couldn't expand the fellowship to 2. And now it's extremely busy. They get a lot of volume and it's a ton of variety. And I'm like a broken record, but I've said it again, man. I want them feeling comfortable being uncomfortable. So when they leave, they continue to learn. Like I don't want them to just keep doing the same stuff.
So what can people expect out of your fellowship in terms of like exposure to different cases and your faculty members and total volume and you name it? Tell me.
No, I mean, if you're talking, let's just start with MIGS. Like you're going to get the entire gambit. We actually, with our tubes, we look at our own results, but even like non-valve tubes, we each use different devices for a reason. So the fellow has exposure to literally pretty much everything on the market.
Great.
You have to do that by design, right? As long as you're making sure that there's equipoise and you're not hurting patients, because we're not. But there's a lot of different tube options. There's different goniotomy options, and there's different stenting options. So from the basics, the fellowship is built on the diversity of your experience, but it's also the diversity of your patient population. I mean, the VA is ours, the main hospital is ours, so you get indigent patients as far as hundreds of miles that come to us. The VA is the same thing, and even on the faculty side, like it's a totally different patient population, and then the clinics. You have what I love is that they have their own clinics and they have their own autonomy,
nice,
and even some select ORs that they run themselves, and it's a ton of teaching. Like they have to staff the residents on phacos and phaco angle surgery.
That is great.
So when you leave, like you've seen it. And if you go into academics, you're ready for it too, because you've already been teaching. And clinically, man, I mean, we all do things differently. There's a huge academic side. CAS is still really involved, so we do a lot of just journal clubs and talking about cases on a weekly basis. But I'm biased, obviously. Like, I love it, but I still have to pay homage to, like, who trained me. I mean, I, like, watched Ike and how he ran his fellowship, and you try to model it off of that because I felt like it was extremely academic and extremely high volume. Right, but you'll get several hundred cases with a lot of variety, and you'll do your share of vitrectomies.
So you're the GAAS, GAAS version here in the U.S., the U.S. version.
That's exactly right.
I love it.
That's right.
Obviously, as a famous fellowship, it's great for a good reason. I mean,
I appreciate it. No, it's been fun, and we're constantly improving every year. I mean, even this year, they're like, "Hey, I think you need to tweak this and this and this in the schedule," and so we have to change. Otherwise, you're never really stagnant. You're either getting better or you're getting worse, in my mind.
I also like the fact that you have a huge variety, like the whole spectrum. Like you said, the indigent patients, the VA patients, county type patients, the private patients, you get everything.
Yeah, you have to, and the faculty work that way too. So like, typically sometimes you might see places where if it's indigent patient population or VA population, the faculty aren't doing anything. Like our clinics are staffed. Sure. I'm at the VA. I pull charts with the resident. So it's not like I'm sitting there staffing. I'm grabbing the patient charts off the main bin that we all share.
You're cranking.
Well, you have to. And honestly, like, you lead by example. I love what I do. I love seeing patients. It's somewhat quality control. But the diversity, man, like, you need that because the diseases might be the same in diagnosis, but the presentations are very different, and the stages at which they present are different, and the social cues at which the disease occurs are very different. And like I said, I want them leaving my fellowship being fantastic and able to handle whatever comes at them.
So are they like often presenting like far more advanced than we'd see normally?
Yeah, and if you look at the vets, I mean, look, man, I will never serve in the military. That's just not my thing. But these guys did something, and like that's why I enjoy going there to try to give back. But it's a lot younger presentation, generally a little bit more advanced when they do present, and it's tough. Those are the diseases like, and Uday, you know this, like peds, right? You get peds glaucoma or peds anything. Generally, there's so much life ahead of them outside. Like ROP is an amazing treatment for them right now, but there's so much life ahead of them. Like you're looking at reoperations, and and when these vets are like early, that's what you're dealing with, and you start to see how but 5 or 6 years later, your tube's probably not working the same. And it's just it's humbling actually because they have so much life ahead of them, but it's also, for me, like a way to give back. And like I said, I like to make sure that I'm kind of in the thick of it with the residents and fellows.
How are you planning for that? Let's say you do have a younger patient with significant glaucoma, and this patient's got like 50, 60 years of life ahead of him or her.
Yeah.
I mean, and only so much conjunctiva, right?
Yeah. Yeah. Now I think my practice's patterns have changed a little bit, leaning toward primary tube shunts, just seeing how our like subconscious filtration surgeries like TRABs, Zens, angle surgery, combined with phaco really does have power. Standalone GAT in the right patient, young enough, really can be efficacious. But we've tilted more toward primary tubes. It reduces the need for second surgeries. And I think now that we have some data coming out as far as do we tube next or in the ASSIST trial, or do we do diode next? Diode's a reasonable option when you have a functional tube. Not that the pressure is controlled, but that you have flow through the tube. And so I think the practice patterns have changed, and I think it's better for patient care now in the long run. And so when we're thinking about planning, I'm like, depending on their case scenario, a lot of these younger patients, especially if the follow-up's poor, are going to get a primary tube when the pressure's in the mid-20s. We'll do that over trabeculectomy. And then we certainly have the other subset that still needs TRABs, but usually filtration, tube, and then probably like a diode.
That's a reasonable approach, kind of guidelines. Now tell me about...
Loose guidelines, exactly.
Right.
Very customized, which is also the voodoo in all of this.
Well, that's the art of it, right? I mean, it can't be just a cookbook. It has to be an art that's individualized to the patient, tailored to the patient.
Yes, and I can tell you that even if you try it as an art, you guess wrong. I mean, you really do. And if you do it as a cookbook, you'll make mistakes too. And I'm more saying that so that people understand, like, I'm not trying to be so definitive all or nothing. It's just, it's how surgery is. It's how glaucoma is.
Right. Ophthalmic surgery takes many years to learn, but a lifetime to master.
Oh, it's so true. It's so true. I mean, like, look, could you even estimate how many cases you've done or been a part of? Would you have any idea?
Yeah.
What do you think? How many tens of thousands?
Yeah, certainly that range.
That range, right?
Yeah, no
and
question.
you still probably will see something different at some point.
Right. Listen, people are blown away when I tell them I learn more from making the Cataract Coach videos than I teach. I assure you, I learn far more.
I 100% agree with that. And there's a reason why I push fellows to edit videos during training. Ike did that with me. It was the best thing that he could have done. It forced me to pay attention to the other details, not just like what I was doing.
Right.
From even visualization to how I make my incisions to how I enter my incisions. It's like things you don't typically critique yourself in the time when you're really locked in.
Right.
But I agree with you. Just editing videos is the best way for a surgeon to learn.
Well, someone asked me, like, oh, do you have someone to help you edit the videos? Can you hire someone? I'm like, I can't hire a non-surgeon to edit a surgical video because they have no concept.
At some point, maybe you get AI doing it for you, huh? I doubt that, though. It's there is an art to video editing, too, man. I mean, look how many people edit videos and post videos. Right. Do they have the same viewership or following that someone like you does? Well, there's a reason for it because it's educational. It's edited well. The key parts are there. The parts that really don't matter aren't. I mean, there's an art to it. And I think that's actually an important thing for trainees to think about is not only are you going to be better, but like you can really kind of push forward teaching too. If you have a really good ability to edit a video, I mean, that's very impactful beyond just your own patient population.
But let me mention for especially the younger surgeons, if you're under age 40, let's say, you got to make sure you're not overcombining. The microscope view has to have the same focal plane as the video recording. Do not keep submitting these blurry videos. I can't use them.
It's so good. It's so good. Yeah, we have that same issue. I mean, I still think I can like over accommodate a little bit, but it's getting to the point where here's one trick though. Tell me. You probably already know this. Just mag up, zoom in, and that'll keep you in focus better than anything else.
Yeah, for sure. At the very beginning, you set it that way, and then also people who are listening, you want to submit a video, learn to use the white balance. Learn to use the brightness. That's true. Set your camera up. Do a little bit of homework, a little bit of reading. Come on.
That's such a good point.
When they're surprised, they find out how much time it takes. Before our call tonight, I was editing a video of explanting a Verisize iris claw lens plus doing a phaco. And to edit a 5-minute video, it takes a long time.
Absolutely, man. I mean, like as far as making sure you have the key steps, the transitions look good, it's logical, and then you do voiceovers. I mean, that's the other side of it, right? Like voiceovers and the text and just like the arrows. I mean, that's you were spending more time editing than you do on the surgery itself.
Yeah, no, for sure. That is a given, for sure. Yeah.
And actually, you know what? It's interesting. Like we're going to be seeing more of these ICLs removed at the time of cataract surgery. This is going to be like a whole thing that you're going to have to start teaching.
With the ICLs, I have many videos of, but I don't have one of a Verisize. The iris claw one.
Yeah.
But I think we're seeing those more now because they're getting really bad endothelial damage. The patient I did the surgery for is about age 50. He got the lens when he was about 30, so he's had it for 20 years. Mm-hmm. And his endothelial cell count went from 3,000 cells per square millimeter to he's like down to 1,400.
Really? Okay.
At age 50, which is like
that's dicey. That's dicey. Yeah, I mean, looking at that, I wish that we had them approved for like aphakia.
That's what I want too.
I mean, it's crazy. Like
you can put it behind the iris.
Exactly. So you could enclavate behind the iris. There's not any angle pressure. The sizing isn't the issue like we have with like MTAs. I'm actually okay with AC lenses because even like
by the way, so am I.
Yeah, you end up having complicated fixation surgeries. That sucks. Like those can be more brutal sometimes than an AC lens when you can see the problem. And in fact, let me ask you this. I've even thought about, if you have like the right patient population a little bit older, why not do like a very small undersized AC lens like an MTA and just iris suture it? Because that's the fix for them when they're over rotating, when they're fit a little too small. And we just suture the haptics of the iris. It's easier than a posterior iris fixation. But I'm kind of like, look, if I'm going to do an AC lens, like maybe I do that. I don't have the angle pressures.
So just measure white to white and then just use that. Don't like upsize from white to white.
Exactly. Or just put a 3UO on everybody.
MTA 3UO. Yeah, the smaller one.
3UO and suture the iris. Look, I'm not advocating that, but it's just interesting things to think about. And I'll tell you, I mean, AC lenses, hundreds I've done. So it's not like I'm like speaking from inexperience.
For sure.
I do appreciate the posterior fixation techniques, and we probably now do more of those. But a good ACIOL technique, I think, should be in every surgeon's back pocket.
Let me tell you, the data shows, the meta-analyses show that a well-done AC lens has no difference in outcomes or performance as a scleral fixated PC lens. None.
That's exactly right. Look, if you're already stacking the cards against you with a complex case that has no capsular support,
Right.
your options are just going to be worse than your in-back options when you have no problems. So everyone's like, oh my God, like the AC lens is causing all these problems. Yeah, it can cause problems, but so can the other techniques too. And I'm so glad you pointed that out.
Right, and another thing people don't realize as well is a well-done Yamane requires a very thorough vitrectomy.
Absolutely.
Hopefully full pars plana
Yep.
and the whole vitrectomy. But if you do an anterior vitrectomy, it's got to be pretty darn good because the number of these cases where you watch the lens being put through the lens is in the mid-vitreous for half these acrobatics. And they're winding up all this vitreous around the haptics, and the patient's getting a chronic CME. Now we see the studies, the rate of chronic CME in a Yamane IOL is way out of proportion.
Absolutely. And if you think about Yamane, and now you've probably seen some of these like reports coming out, you know, the lens has these little haptic twists.
Yes.
And so like you'll look, like post-op, it's looking great. And then day one, like it's extremely tilted. This has been going around on multiple listservs. It's not fraught without issues. I mean, we've explanted probably 2 or 3 now that they were causing problems in the last like 6 to 9 months.
Right.
So yeah, and here's the thing. Like, aphakia is actually okay too. If you're just not the right person for it, and whatever you're going to do is still going to have a high chance of a second surgery, just leave them aphakic. It's okay. Let the dust settle. You can give it to someone that's doing it more often, and that's perfectly okay. But I still think if you had a proper AC lens technique, you've probably had patients uncorrected like 2020, 2025 with an ACIOL.
Yeah, plenty. Especially if you're smart enough, by the way, I got to say it here. Please stop putting AC lenses through 6mm corneal incisions. Use the scleral tunnel, people.
I love it. You know what's awesome about that is I am such a clear corneal incision guy.
Oh, really? Even for those? Like that's 6mm wide?
Yeah, like
Oh my God.
5.5 to 6, and a like a running mattress suture. But I'm telling you though, it is important to talk about because like scleral wounds, I do think scleral tunnels seal better. You want to make sure they're sealed, otherwise you could potentially have like a chronic leak and fibrous downgrowth. That's very uncommon. The corneal suturing though, you got to make sure that you're paying attention to how you're suturing. Like if people are like driving in and they're like mashing the top part of the cornea against the bottom part and it's leaking and all the sill and astigmatism, it's terrible. But you can operate on axis, relax quite a bit of cylinder with like a larger incision. The sutures generally you can take out a little bit easier. You don't have to worry about lasering. Yeah. I could see a plus and minus for both sides, but I'm not going to argue against you. I think it's totally reasonable. And scleral tunnels are a dying technique. So there's another reason to make sure people know how to do them.
Well, you know, this Verisize video that I was editing, I actually showed a contrast for me doing a case years and years ago where I did a basically limbal corneal incision, 6mm to explant it, sutured it up, and patient okay. And then this time, the one I just did this last week, and I'm editing the video for, I did a scleral tunnel. Yeah. And I don't know. Maybe I'm an old guy. I'm more used to that.
I do think the wound integrity can be better, actually. And if you do it right, the problem is, I think people don't do it often enough.
Sure.
And so they end up sometimes a little too posterior. And now you're right up against the iris root, and it's prolapsing, and they hyperinflate. Sometimes if you're a little bit more anterior, maybe you can prevent some of that stuff. But you get into those situations and things are already on a bad footing. And that's why I say aphakia at the time of like a major complication is okay if you're not used to dealing with it. You got surgeons doing like 2,000-3,000 cases a year with maybe like 1 or 2 vitrectomies a year. Yeah. I mean, how often are they going to use an ACIOL? Once every several years, right? It's very uncommon.
Well, especially I had someone asked me about a case recently where they had a broken bag and retained nuclear piece of the vitreous. And I just said, let me give you permission. It's okay. Just close the eye and let your vitreoretinal colleague clean up everything and put the lens in.
Yeah. I think that, especially if that's what they're doing on a daily basis or a weekly basis. Absolutely.
There's no shame in that. I think my saying was, share the love And the liability with your retina colleague.
That's right. That's a good way to put it. I like that.
Speaking of videos on Cataract Coach, we had your bang video, which I thought
Oh,
was
sure. Yeah. You were really nice to put that out there.
I loved it. So tell us more about the procedure. If you haven't seen it, you just got to go to CataractCoach.com, type in the word BANG in the search engine, and I promise it'll come right up.
Well, I'll give you some funny background to that, actually.
Teach me.
So it really started because, again, like we treat a pretty large indigent population, and patients that were like on meds, even like on the resident service, that everything that you add still has cost. And so for goniotomies, it's literally just like a reverse cystotome, essentially. There is a little bit of technique to it. The nice thing about it, Uday, I love the fact that when people do it, like our trainees do it, it really makes you hover into the canal. You push a little too deep, it'll tell you that you're catching the back wall. But you take like a 25 gauge hypodermic, you can use a 27. As long as it's 5/8 inch long, you'll cross the angle. If it's a half an inch, there's some angles you're not going to hit. And you can use a needle driver. Mateen with Epsilon has like a little bender that you can actually buy, and I have zero financial interest there. It's not named after me. I don't want it to be, but you can bend this needle to the point where it gives you almost like a nice little curvature to it. And the goniotomy part actually works nice. We have like some early results that we published. We're collecting much longer term data. But it is a way to do a goniotomy relatively cheap. Now, the devices out there that do goniotomies, I think they're probably better at collecting trabecular meshwork. So we run some research studies, and Carlos Siegfried's like the lead on a couple of these glaucoma projects. And I think we all agree like it's probably better to collect the TM if you're trying to take it off. But as far as jumping into angle surgery without like a big commitment just to see like what it's like, I think it's a nice way to jump into it. But the funny thing about the name, I got to be careful how I word this. I'm hardcore into academics. I'm in it. I don't think that's ever going to change. But I do think we take ourselves too seriously. And so I remember when we first did it, it was actually on a healthcare patient, worker who was a patient, and kind of followed it out. I was like, you know what, this might be like a thing. And then we started it a little bit more on the resident service. And then I was at the VA, my fellows across the hall. I was like, Tommy, I'm going to call him out. Tommy Shoot, great guy. We got to come up with like a name for this so it sticks. And I don't want it to just be like every other kind of name. So we actually really came up with the word, like what would be just like a weird word that would kind of be out there. And then we could kind of fit the acronym into it. So it was a lot of fun kind of going back and forth and
that's great.
Just bucking the trend a little bit, man. We take ourselves too seriously with some of this stuff.
Oh, that's fantastic. So yeah, I think the neatest part is, we have a lot of cataract coach viewers from around the world. Mm-hmm. And there are a lot of patients and doctors in places where a lot of these fancy supplies and fancy instruments are just not possible.
They don't have it. Yeah, New World does well sending stuff out there. I don't want to speak for Sight Sciences, but there's a goniotomy device that they have, and I'm sure if you talk to the company, they're still really in it to help patient care. Sure. And so if you had a need internationally, I would reach out to them first. But if you don't have access, this sutured GAT, those are two ways to address the angle without leaving a device and being able to actually try to impact patient care that way.
And so with the suture GAT, you're using a 6-0 Prolene. Are you doing that little softening of the tip of it with a little cautery too? And all
that? I cauterize a little bit. Prolene's going to be better than nylon. You can use both. Certainly the catheters that are out there on the market, they find the angle better.
Sure.
Maybe that's the wrong way to put it. They track in the canal better once they're in. And so I think with the sutured GAT, the nice thing is just accessibility as far as the cost goes. And I'll tell you, there's data out there now that you probably don't even need to do like a 360 treatment. It could even do fine with like 180 to 200 degrees, probably a little bit less bleeding that way. But yeah, it's that has changed glaucoma on the adult side. It's funny because Peds was doing a lot of angle surgery before the adults got on.
Yeah, 20, 30, 40 years ago, forever ago.
Exactly.
It's kind of funny how that all works out.
It does. But we applied it appropriately, right? Like, in pediatric glaucoma, it's a very different mechanism in some respects. But if you're looking at like anterior TM-based obstruction, hopefully your collectors are still functional and patent. Some of the assumptions, which is why we start with goniotomies and trabeculotomies, ab external or internal. And MIGS, angled MIGS, and I think this is where people really need to understand, it was designed for early in the disease course. That's when we know that some of these things work better in the kids. Now you still have to do trabs, tubes. But angle surgery, when you start to really push it, people that have been medicated for like 10 years, like, their mean deviations are minus 24, and they're not under good control, probably not the best candidate for an angle procedure, right?
It's just not enough, right?
You're going to have these anecdotal wins. I'm not going to argue against that, but by and large, that's probably not the right way to go.
Are you doing a significant peds population too?
I was actually doing a little bit more peds. Our peds service is fantastic. This was up until maybe like a year and a half ago. Most of it now that I do is on the anterior segment side, or if they've already had like a ab external goniotomy or trabeculotomy, or even like primary tube shunt or trab. Our peds docs are great. So
wow, your fellows really do get the entire spectrum.
They really will. And if you're peds oriented, and I always am very honest, like we don't have a true peds service, but you can get involved. They actually go and rotate with our pediatric ophthalmologist to observe surgeries. And if you're really into peds, maybe it's not the best place here, but you do so much angle work, you're ready to go. I just don't want to end up being the one responsible for like amblyopia, right?
Yeah.
But like the microsphere phakics, Marfans, dislocated lenses that they still get, post-traumas. I will never forget a case that I did with one of our fellows who, Uday, you should have seen this eye. The iris, it was such a large iridodialysis, like 6 clock hours. It was scrolled up into the visual axis with a dislocated cataract and high pressures. And this kid, it's great because, he was really into like bull riding, and he was like maybe 11 or 12 at the time, and he'd come in cowboy boots. It's just the cutest thing ever. And that eye was literally 20/20, despite a macular scar. With the iris fully reconstructed, iridodialysis repair, unfolding the iris in order to suture it for a pupilloplasty, a capsular tension segment for the cataract part. Those are the moments, and I'll tell you, like, I always have them every year where I'm just like, wow, the fellow just did that.
That's cool.
It's so cool. It's so cool. Gives me goosebumps even talking about it.
Oh, that's awesome. Yeah, those kind of patients that makes you thankful to be an ophthalmologist,
Yeah, absolutely. It's funny. I'll never forget, like, my first, it was an extra cap at WashU. We were a little bit more traditional at the start. We would start with extra caps, and it was a nonverbal patient who, his sister brought him in because he had bilateral dense cataracts, and maybe he was like in his 50s or 60s, and nonverbal. And she was like, he's just been so much more depressed. Like at the skilled nursing facility, they're saying he's like eating less, he's losing weight. We think he can't see, and they were right. The cataracts are really dense. So I extra capped one side. It was, I think, my first extra cap, and probably like my second like cataract surgery ever.
Yeah.
And so the next day, they're under a block. So the next day he's patched, and they take the patch off. And he looks around the room, and he sees his sister. Huge smile, and he just starts waving at her. And she looks back, and she just starts waving back. And they're just going back and forth waving. And I'm sitting here like this bystander, like witnessing, like, it's pretty special, and she was like in tears, like she hasn't seen him smile. It was like, that gets you hooked. I think you do that, you really get hooked.
Now tell me about your path to ophthalmology, and actually specifically even glaucoma. What made you choose
glaucoma,
ophthalmology?
and it was not ophthalmology, Uday. I was my dad was a pulmonary critical care doc in Baton Rouge. For many years, he was like one of the only burn unit attendings, actually. So busy. He was working 7 days a week. We just knew, like, on Saturday, Sunday, he was going to come in after he rounded, and we'd eat lunch together as a family every weekend, but it would be always later. He kind of actually steered me toward WashU because they had a really good pulmonary critical care division. So I went there for medical school, and then ophthalmology kind of sprung up a little later because actually what I wanted to do was, I will never forget his name, and I'm going to call him out. It's Israel Ziegelboim. He was a gyne-onc fellow, fantastic guy, and this will make a little bit more sense as I kind of progress, but gyne-onc to me was like the path I was going to take. Okay. And it was because it was patients that really didn't do a whole lot to get the diseases that they got, and they were terrible diseases, and I think the surgeries were lacking. It was really tough. I could not do labor and delivery, so I don't know how I would have done like with that residency, but then when I went into ophthalmology, that was also a different kind of pathway. Somebody else introduced me to it a little later in the game. I was thinking I was going to do retina like everybody else. You see the retina and it's great. But then You started thinking about glaucoma, and that's a disease, again, that's not self-inflicted.
Yeah.
And it strikes, and you don't know why. I mean, we still generally don't know why. And it's chronic, it's long-term. So you're truly doctoring. You're trying to be preventative. You can intervene with medications. You can intervene with surgery. But you have to be able to counsel the patient and talk to them and get them through sometimes what could be a very blinding condition that you know they're going to lose vision from. So to me, it's the consummate doctor in treating diseases that aren't self-induced. They're truly diseases. But in my mind, the glaucoma surgeon, the glaucoma doctor is a true physician.
And the nice part is, too, you have that longevity where you treat the patient longitudinally over years to decades.
You do. And you can try to, like, I'll try to run my practices more of a, like, consultation service. Like, patients are coming in and we're trying to get people in that need surgery. Because, I think all of us are overrun. But they still come back. Like, it's not like you still have chronic long care patients no matter how you try to run your service.
Yeah, I mean, that's the one tough thing for me doing just cataract refractive, where, listen, it's catch and release. When your surgery is done, when you're bilateral pseudophakic, I almost never see you again.
Well, cataract surgery is such a fantastic surgery. That's the other side. I didn't want to give that up.
Yeah.
It's not that it's easy. It's that ophthalmology has made it so reproducible, and the training is so good that you can get fantastic outcomes across a broad population of surgeons. Yeah. It doesn't make it easy. Yeah. It's just that we are so good as a field of fine-tuning this thing. And that's a tough one to get rid of. Actually, our retina fellows, we get them doing cataract surgery, because I think many retina fellowships are kind of like, oh, you're just going to do retina, because of practice patterns when you get out into practice. But I love it, man. I don't know if I could continue to do ophthalmology if they told me you're done with cataracts.
It's the fun surgery. I mean, obviously, with CataractCoach, I'm cuckoo for cataracts. There's no question about it.
But I'm telling you, it's so critical, because most people are going to have that in their practice. So the stuff that you're doing on education, it's extremely impactful across the board. I mean, this is across subspecialties, right? Like from comp to glaucoma to cornea to some retina. You have some neuro-op people doing cataract surgery. Like, that's a broad reach.
Yeah, I saw my confession, too, regarding retina. When I was a first-year resident, I was like, I'm doing retina for sure. I'm doing retina. And then, like, I started to do, like, cataract surgery. Like, whoa. I'm like,
it's pretty nice.
I know. And then I'm older, so I finished residency in 2000. So when I finished residency, there was no anti-VEGF, there was no OCT machine. They were doing macular translocation surgery for macular degeneration. That didn't work out so well. So it was a really
that was crazy. What a wild time, like going from that to intravitreal injections to take like a surgical disease and turn it into a medical, right?
Right. But I think the one part where we may have not done a great job on the retina side is the amount of funds shunted over to companies making anti-VEGF drugs. It's staggering.
It is a lot. I mean, look, I'll tell you, I'll probably be the last to talk about cost, because I think a lot of times, like, we don't have all of the variables, you know. Yeah. How is it as far as the patient follow-up, and like when are they pulled from their job, and how many people does that impact? And so it's not always like just the cost of the surgery or the device, but we do funnel a lot of money toward wet AMD. It's a lot of money.
But I'm just saying, even the proportion of the money that's paid.
Yeah.
Surgeon fee versus drug company money.
Oh, yeah, sure.
It's like 95 to 5%.
I don't know those numbers, but I know they're pretty tilted in that favor.
Let's change gears for a second. Talk about a little bit more academic life, academic ophthalmology. So I don't know if you know, I actually retired from teaching residents late last year.
No, I didn't know that.
Oh, 22 years. I did my time. But it's time. I thought it's time to change gears.
Yeah.
And so for me personally, I loved it. I did it for a lot of years. I attended, I'm guessing about 10,000 retina cases, cataract cases, maybe more, over 22 years. And I had basically 200 residents, because we're 8 residents a year. Some years 9 even. So we had a lot of residents we trained. I had a fantastic time. And it was really, truly an honor. But I think it was just time for me to change gears. I had nothing left to prove.
Yeah.
I don't want another teaching award. 5 was enough. I don't need a 6. Here, they're on the shelf right here above me, right there.
I love it, man.
I don't need any more.
Isn't that a great feeling too, though?
It is. But it was a fantastic time, and I do certainly miss it.
Yeah.
I love interacting with the residents. I miss the ultra sweet county hospital patients.
Yeah.
The nursing staff, etc. But It's also, I think things are changing now. There's a little bit more admin grief, bureaucracy coming into academics that I didn't see years ago. Is that across the country?
No, you nailed it. I mean, I don't have that broad perspective like you do, but just jumping into the program director role several years back, it is concerning. The amount of administrative headaches that physicians in academia have with a dwindling reimbursement structure. Look, it's the same, you know this, it's the same pressures in academia as in private practice as far as like, you got to make your salary. It's not like the money's just appearing in midair. Now, if your chair's got a ton of like chaired positions that he can offer people, fine, there's like an offset. But there's a reason why, in general, the salary is going to be lower in academia, because residents and fellows are going to slow you down. They don't make things faster. And that's like the whole misconception. Now, the flip side is, I love what I do because like in June, I mean, we alluded to this, like you see where they're at, you're just like, this is incredible. And then I hit July, I'm like, oh my God, what's just happened here again, you know? But the academic lifestyle, I do want to like impart on people, it's not for everybody, it's all you know, but most people are going to be happier in private practice, and there's nothing wrong with that. And there's nothing wrong with running a proper business, being efficient with it, making a good patient experience, to the point where I love that we lean on our private practitioners in our community to actually help our residents out. We hold like a dinner every year, talk about contract negotiations, and there's usually only one faculty member that's there. The rest are doctors that partner with us in private practice. Most people are going to do better in private practice. And academics, like what's interesting is you kind of see this divide. Like people that are really young or just a little bit older, there's not a whole lot in the middle. And what tends to happen is they kind of like are like, wow, you know, I'm still under the same pressures to produce, same pressures to like run a volume to make my salary. And I still then come home. I mean, my wife's a great example. Like we were both in academia, and then after a couple of years, she decided to part ways, and we would both come home and have like an hour and a half, 2 hours worth of work on the laptops. We'd sit together, kind of do work. And now she comes home like, yeah, she's got other stuff that she deals with. But that whole administrative burden side is gone. And I do think, especially now in today's culture, we're losing the ship a little bit with what's happening as far as the check boxes and the metrics and the bureaucracy and creating more work to create more jobs that create more work and the oversight. I mean,
how many more middle layers of admin?
Unbelievable.
Right? Just the layers and layers upon admin.
Layer and layer. And someone comes in, they got to justify their existence, so they're going to create a new rule. We never peel back rules, we just add them.
Well, you know, I think there is one more option, which is what I did. So actually, for all of my 22 years since I finished my training, I've always done a private practice and separately some academic stuff, and did a hybrid.
Yeah, I think that's a great solution. Actually, that's probably most people, I think, like just looking at our residents, they really think hard about going into academics because that's all they know. And I just told you, like most people should not be in academics. That type of a model is something that I'm seeing more and more of people wanting, where they're affiliated with universities. But you know, Uday, that was like the original way. Like it was like ophthalmology and ENT. Like many like East Coast universities had just not volunteer, but like affiliated faculty that had practices that would come in and teach. And there's still programs like that. Do I think that's going to go that way? Probably not. I think most places are full-time and they're going to stay full-time. But there is nothing wrong with that model. And it keeps you young. It keeps you on the cutting edge. You impact people beyond your own patient care, which I think is probably like the part that I love the most.
Yeah, I brought a lot of my private practice kind of mentality and know-how for efficiencies to the county hospital. When I took over as chief of that county hospital like 15, 17 years ago, they were booking 4 cataracts in a day. Yeah. And so I was like, okay, so first thing we're doing, I said, we're doing 10 cataracts every day. 10. That's what we're doing. Yep. And it's going to work. And here we're going to track all the metrics, and we're going this. And you know what? It worked.
It works. It works. It's so funny you mentioned that. You know, there are built-in inefficiencies in academia, and some of it is just because you're teaching, like you're going to take a little bit more time. But that does not mean that it has to be as inefficient as what it is. Same thing. Our VA in the morning, gosh, like we were doing maybe like 2 to 3 cases. Now the residents like churning like 6 or 7 phaco combines with glaucoma. Nice. You know, and sometimes it's like a tube, or the fellow's going to do like an IOL thing, but it's a completely different ballgame. But it requires buy-in by your staff. Yes. Like at our VA, the staff really does buy in, like the nursing staff, to help patients out. Here's a good story you're gonna love. When I was a resident, we had a huge cataract backlog because it was so inefficient, and I got frustrated hearing patients coming back like they wanted their second eye done. And so you're seeing them in your post-op clinic, and it started with this bus driver. She was so furious that she was going to have to wait another 6 months to get her second eye done. She's like, I can't do my job.
Yeah.
I was like, you know what? Why don't you contact like our congressional leadership, like staff at the hospital? And the patients did the work, and they did, and eventually they opened up ORs for us on Saturdays. So we started operating on Saturdays when I was a resident. It was great. So it was a true 7-day work week, but you're doing cases even on the weekends. And
but now program director, work hour restrictions.
Well, yeah, you can't. That's true. That's true.
Different world, buddy. Different world.
That's so true. You know, but like it really did. It kind of forced them to think about like, we don't clamor for efficiency because we're just trying to do as many cases as we can and get home.
You want to help as many people as you can.
You're trying to help. People are stuck in line waiting for care.
Yeah.
That's why efficiency matters. And academia can still be efficient. I got friends around the country. I mean, I'll tell you, like Joe Panarelli at NYU sees a lot of patients. He does a lot of surgery, hardcore glaucoma surgery. He's in academia. He's teaching. It does not have to be mutually exclusive.
Sure. Yeah, it's just, I think, keeping in the idea, too, that the way you practice today is going to keep evolving.
Yeah.
So you don't, as long as you don't get stuck in a rut, you can always keep thinking, all right, what's next? How else do I keep evolving this? And keeping that mentality, not only, we're used to it on the surgical technique side. Oh, I want to evolve to this technique and this technology and this new device, but also in the way you run the practice.
Yes, 100%. And honestly, if you are only doing what you were taught, or only doing, let's say this, like your first couple of years in practice, however you ran it efficiency-wise, whatever cases you were doing, if that's all you're doing 20 years later, you probably have not kept up with it, right?
Yeah, we've all seen that. We've seen the guy or gal in the community who's like, nope, even 30 years later, I'm only doing what I learned in residency.
No, you're not helping people. Now you're practicing medicine that's 30 years old.
Yeah, for sure.
Right? So that's the care that your patients are getting, is the medicine that you learned 30 years ago. That's not the right way to be.
You mean that doctor doing macular translocation surgery is not good? I'll just joking, obviously.
No, I know, man. I know.
So let me ask you this. So now as being involved in residency programs and program director, how do you choose a good resident now that fits your program when you don't have USMLE scores? You don't have grades anymore because schools are pass fail, and they even said that AOA is bad these days. So no, I don't, because I'm of the old school. I believe in like junior AOA and great board scores and top year class, and
listen, I am with you. You know, if there's a test that is like truly fact based, like the USMLE, and it's not like built for interpretation. I do think we need to change how sometimes we look at like just the outcome measurements and then try to backtrack.
Sure.
It's really tough, and it's working. I mean, applicants are looking the same across the board. Doesn't matter what school you're from. Doesn't matter where you might have been in your class. They just blend together now. So the societal metric of neutralizing everyone is working. And actually detrimental to many people.
You bring down the high achievers.
Yeah.
To neutralize everyone.
You neutralize everyone. And we're getting to a point where people are going unmatched. I mean, it happened this year, unfortunately, even like with some of our own medical students. They're top notch. The Zoom era is also killing us a little bit. You can't really get a sense of like what that person is just on a screen.
Sure.
And like there's no interaction with them anymore. I hope next year we go away from that. And away rotations might matter a little bit more, but I'll tell you, like, if there's gonna be one thing that I'm gonna say, and I talk about this, the problem is like people that have heard me say some of these things are gonna be like, oh gosh, it's the same thing over again. But these are some truisms that I really do value.
Teach me, I want to learn.
Well, it's super simple. There's nothing like gonna blow your mind, but I am looking for someone that is going to try to better the people around them. Like, we remember classes like years of like wine, right? It's like a good year for that wine or a bad year for that wine. It was an okay for that wine.
You're right.
I don't remember like so-and-so stood out above the rest and they were kicking everyone down to get there. No. In fact, if you're trying to make everyone else look really good, the entire faculty, we're all going to remember you as good. That's what I'm looking for.
That when the tide rises, all boats come up.
Exactly, man. That's how it is, and people lose sight of that. And sure, it's good to have competition. It drives you. Have your own internal competition. There are going to be certain skill sets that you will never have compared to somebody else, and vice versa. So be internally competitive, and your goal should be to lift everyone up around you. And then you are going to be successful no matter what you do.
Wow, I love it. And so, it's funny you say that. So for my 22 years of working with residents, you always remember those classes that I called cohesive classes.
There you go.
That year, all 8 of them were like cohesive, together. And the way you could tell is, because they all have different rotations, that during the rotation, this resident would book his schedule packed with cases. Mm-hmm. And then the first week of the next rotation, he's also booking equally great, tough cases and equal volume cases. As opposed to the bad year class where they were not cohesive, that resident was like, no, he'd only book all the great cases for his block.
Yep.
And then for the first or second week of the new block, he'd just put all the junk cases there, and put very little volume. And just like, what?
I never understood that. I didn't operate that way as far, not like surgically. I'm saying like how I interact with my peers. I was really fortunate to be with the group that I was in. They all were just that same way. It's just selflessness, right? Like you're a physician, like isn't that the goal? But it's amazing to me, Uday. Like you see some of these people coming through, and like their whole goal is to just like stand above the crowd. But it doesn't work. It actually comes off like in a negative way.
Yeah, 100%. I still remember when I was a co-resident, I'd have a patient with a really tough case, like bad pseudo exfoliation, Dutch cataract. I'd only do the one eye and save the second eye for the resident who was following me, which is my buddy John Lattis with the Lattice Super Formula and the AI and all that. We were co-residents. So we'd always like save each other like, oh, I did one eye. You got to do the other. We got to compare notes then afterwards.
I love that. Man, like in fellowship, the same way. Harmon, co-fellow, I couldn't ask for a better one.
Sure.
And we would do the same every day. Clinic or OR, we'd get on the phone. Hey, this is what I did. This is what this one faculty liked. Here's the mistake I made. What did you do? You're sharing knowledge. Like that's the best way for you to end up just being better. But that's really the simplistic way of like, who are we looking for in the resident? Now, the problem is it's really tough to find that. Letter writers now, you're not going to ask someone who's going to write you a bad letter. You're gonna
all the letters sound the same.
They sound the same. And this is why, like now, if you're neutralizing scores, things are going pass-fail, it's a crapshoot. And remember, the SAT was put in place to neutralize the playing field. Correct. So we didn't have legacy people getting into the Harvards and Yales. It was so you could be from like a school that wasn't a classic Ivy League and have a way to separate yourself and now be compared to the people that were legacies. And now all of a sudden we think it's a bad thing.
Now we can do it with the checkbox instead.
I mean,
that's
the problem. That's not why my parents moved here, but that's a different conversation.
Yeah. I totally get it, but it was one of the reasons why I wanted to also pull back from academics. I thought that was very frustrating recently after doing so many years on the residency admission committee. It just became very difficult, and then
there are external pressures that I would rather not comment on that I think are misguided. They come from a good place, but they're guided improperly, and it does put strain on people that are trying to do the right thing when they're residency directors. That's just how it is, and you will lose good people in academia because of the way that academics sometimes is responding to social change.
Time will tell. I guess we'll just
see
what plays out.
It's always going to play out to the ultimate truth.
Yeah.
I mean, if you expand time far out enough, you're going to get there. You try to force something, and eventually it'll still wind up where it should be. But yeah, I mean, there's some good in what is happening, but the burden, the academic burden and the administrative burden is going to keep some really good people out from doing this.
So now you don't blame me for retiring after 22 years?
Oh, not at all, man. Are you kidding me?
I was like, sweet.
I like view myself as like a sucker sometimes, man. I will admit that. I love what I do, and I'm not as far out as you are, and I might change my tune down the line, but yeah, it's not easy. I would never call it easy.
Well, I figured out all the paperwork. Like, what's the soonest I'm allowed to retire and take a pen? And they're like, 52. I'm like, perfect.
Done.
I said, let me just bow out gracefully. And I didn't drop the mic.
Yeah.
I passed the baton to the next generation of people, people who are just in your 30s. It's time for them to shine.
100%.
I never wanted to be that guy who's going to be sitting there still teaching the residents for 50 years after my residency, and like, no, I didn't want to be that.
No. Pull. I would actually respect that. Pull out when you're on top.
Yeah.
When you're at your prime,
Peaking.
you are. Yeah, it's a disservice when you continue to kind of hang on to that. At some point, like, I'm not going to be the clinician and surgeon that I am now, and I'm okay with that. We will all hit that point. I just hope I can recognize it before I really start to slide.
That's true. Hey, so I got to tell you, I'm looking forward to seeing you just next week.
That's right. We're going to be together, man, in New Orleans, not far from my hometown, man.
The New Orleans Academy of Ophthalmology. That is a fantastic region.
I've never been.
Oh, I've been multiple times.
All right, well, let's do it, man. I think
the
topics are great.
Oh, I have a whole bunch of cases to show.
Awesome.
We're putting you, the panelists, on the podium, on the spot. I'm not going to tell you anything in advance.
Don't clue me in, man. Listen, probably people will gain more from one of us up there just making like a boneheaded call than if everyone's like on point with what we say.
Well, most of the cases are actually me making a mistake. And so you're all going to be poking fun at me and correcting me. So
no, that takes true humility, man. I appreciate that.
But that's going to be a fantastic time. But I look forward to seeing you there and talking more in person. But wow, I really admire your passion. I think the energy you bring to this field is just superb. I mean, I remember hanging out with you at one of the Millennial Line meetings a few years ago, and you had an infectious enthusiasm, and I think that's so impressive. And I think it really you are affecting a huge change on like the next new generation of guys coming out.
I really appreciate that.
For my resident, for Gio to say, no, Dr. Devgan, I've looked at all the fellowships. This is the one.
I don't see how that's a thing. It's extremely humbling to think about. I mean, I look at what you've done, and you're telling me that, and I'm like, just stop. No more talking about this. But I really do appreciate it, man. I remember my dad coming home one day with the resident teaching award, and it was like a plaque with an apple on it, and he was like Teacher of the Year, and probably one of my most proud moments of what he does, and he's done a lot. But anyway, I don't take things like that too well, so I think we can stop there. But I really do appreciate you saying that.
Oh, that's awesome. And your dad has forgiven you for going in an ophthalmologist instead of pulmonary critical care.
Yes.
Even if you're not doing pulmonary critical care, you're still okay.
Well, now I get to take care of his friends, so I think we're okay. He's happy about that.
Hey, once you start making his friends pseudo-faking, they'll love you. Like, wow, your son's the best.
That's exactly right.
That's like the best magic trick in all of medicine.
It is. It's unbelievable. What a great surgery.
It's just a magic trick. So anyway, beautiful time talking with you. I really enjoyed this. I bet our viewers are going to love this. Thank you so much for taking the time. And I want to remind everyone we can get all these podcasts on Apple, Spotify, Google, Amazon, wherever you like your podcast. And we're going to keep up with these podcasts every other week coming up until this summer. Then we're going to go every week.
Nice.
Yeah.
Nice. This is fun, man. I really do enjoy hanging out with you, and I'm glad you got me on this, and we're going to see each other soon.
Thank you for enjoying this interview with Dr. Arsham Sheybani for podcast number 7. Fantastic. I know that you learned a lot. It was very much worth your time. And guess what? We've got even more podcasts to come. We're going to continue with every other week podcast until about June of 2023. And then we're going once a week. That's right, once a week. We're going to do 52 podcasts a year. And guess what? You know a guy right here who always delivers. It's going to be fun. I hope you stay tuned. Take care.